Good afternoon. My name is Gina Wen. I'm SMID-cap biotech analyst out of Barclays. It's my great pleasure to introduce our next speaker, Bruce Given, Chief Operating Officer and Head of R&D of Arrowhead.
Good afternoon. Thank you for the invitation to speak. I've been asked to move very quickly through the slides, so we have plenty of time for Q&A. So I'll go right ahead here, assuming I can get this to advance. There we go. Because I'm moving quickly, I would encourage any of you to be sure to take a look at our forward-looking statement. So we're going to talk today about our platform, which is the TRiM platform. It's in cartoon form. It's quite simple. It's a double-stranded siRNA molecule that's been heavily modified to survive the body's many defense mechanisms against such molecules. And then these double-stranded RNA molecules do not tend to traverse plasma membranes easily. So to get into cells, we target them to internalizing receptors through targeting ligand. And then when we are going outside of hepatocytes but doing systemic delivery, we generally have to use some sort of PK enhancement as well. So in cartoon form, it's quite easy, simple molecules. In reality, there's a lot of sophistication here and a lot of optimization that's gone on over the last several years. And the molecules are tending to perform quite well now. One thing that we have shown now is that we can knock down genes of interest, not just in hepatocytes, but also in other tissues of interest. And we can do this dosing sub-Q, IV, or inhaled. And this gives you just a sense of the power of the technology. This was our first TRiM molecule to go into human testing. If you look on the right side here, you'll see that after a third monthly dose, the duration is easily a good 12 weeks or so, indicating that we believe with chronic dosing, we'll be looking at quarterly dosing with this platform. And in some situations, we may even be looking at something longer than quarterly, for instance, every 6 months. So these molecules give very deep knockdown and give nice durability. What's also been very encouraging is that the tolerability profile has looked very good. We haven't seen any dose-related tolerability issues. Most things look very similar to placebo. The only real exception to this is somewhere in the order of 10% of injections are associated with quite mild injection site redness or maybe a little bruising, but all of them have been mild so far. No patients or volunteers have been close to wanting to discontinue because of these injection site reactions. So we've been quite gratified by the tolerability. Many of you may be familiar also with our findings in hepatitis B. Here again, we're looking at monthly dosing, these data were quite impactful, I think, in the hepatitis B investigator community. All of the patients in this early part of the program have achieved greater than a 90% reduction or greater than a 1 log reduction in S antigen, and this has sort of been the holy grail in HBV. As you can see, over 80% have achieved a 97% reduction, and over a third, a 99% reduction. So these are the kinds of reductions in S antigen that the field was just hoping for, indicating, again, the power of the TRiM platform. And once again, the adverse events have been generally mild and no real indication of any sort of dose-relatedness, and the sorts of things that you would also expect to see potentially in placebo subjects as well. So on the whole, again, tolerability has looked good. And this led to a partnership with Janssen that included the HBV program, but also the opportunity for them to work with us on 3 different targets that they would bring to us. So the important thing is that these targets are found targets. They're not using targets that we ourselves have identified. This was a valuable deal, $3.7 billion in total sort of biobucks, $250 million up front, of which 75 was equity, 175 was cash. There's another $1.6 billion in potential milestones in the HBV program, and then there's $1.9 billion in these three potential partner programs, and then royalties as well. This was important to us because it added to the validation that we already had received with the Amgen deal that we reported at the end of 2016. This was the right partner for HBV, and we could talk about why we think that if Gina would like to. And of course, there's never a problem with having capital on your balance sheet when you're a development stage biotech. So a year ago at this time, we were maybe just starting to dose our first patient in AAT in the TRiM platform. As we stand here today, as I stand here today and you sit there today, we are in humans with 5 different drugs in the TRiM platform, including alpha-1 antitrypsin and HBV that we talked about. But in addition, we have 2 programs in hypertriglyceridemia. These are wholly owned by us, as is AAT. And then, again, the hepatitis program and also the Lp(a) program, AMG 890, which was licensed to Amgen in the fall of 2016. So we have 5 programs in the clinic, 3 of which are wholly owned by us. And then we have partnership opportunities, obviously. Up there in the middle, you see ENaC and HIF2. These are 2 programs that we've said we intend to try to get into the clinic this year. What's interesting about these is neither of these are hepatocyte targets. So this is a very strong first foray into the extrahepatic space, which is a big frontier for RNAi. So just a couple minutes on the hypertriglyceridemia programs. One is ARO-ANG3, the other ARO-ApoC3. Both of these have very strong genetic background data from GWAS indicating that there are already the human experiment of knockdowns of these particular proteins, and they have been associated with dramatically reduced risk in cardiovascular disease independent of LDL cholesterol. So this is completely orthogonal to LDL cholesterol. What you see here circled is the cardiovascular risk in patients who are heterozygotes. So they're just 50% reduced in ApoC3 or ANGPTL3, and you can see they have a 40% risk reduction for cardiovascular risk. So these are important new risk factors similar to Lp(a) or LDL cholesterol. And if you look one box over at the very bottom here, you're looking at the homozygotes. There aren't enough of these patients to be able to tell what their risk reduction is for cardiovascular, but there are enough of these to look to see whether they pay any price for having the genetic loss of ApoC3 or the genetic loss of ANGPTL3. And you can see that they say both of these are nondescribed. So nobody's been able to find any payment that the patients are making for having lost these genes. So we think that they're going to be safe and well tolerated. Financial highlights, we ended the year with about $300 million in cash. Last year we burned about $60 million. We think we'll burn a little bit more in coming quarters because of our clinical activities. So we're thinking maybe $20 million a quarter going forward, at least in the shorter term. So we're in a good situation with cash. So looking forward in 2019, we expect this to be very productive. We have activity to report in AAT, ANGPTL3, and ApoC3, our wholly owned programs. We expect the 2 new CTAs in HIF2 alpha and ENaC. We expect progress in ARO-HBV and AMG 890 with our partners. And then the wild cards are what may or may not happen with Janssen targets. If they get us working on these targets, we'll see what happens. We have this undisclosed target with Amgen that at some point they have the option to make a decision on. We have work going on in muscle, and then there's always the unexpected arrowhead breakthroughs, which we've been producing quite a few of in recent years. Thank you very much.
Thank you, Bruce. So that's a very helpful overview. So maybe I would just start with technology, given your background. So just wondering, how do you compare your technology versus other RNAi approach, for example, Alnylam's GalNAc?
Right. So at the cartoon level, it's similar. They also take double-stranded RNAs, heavily modified, and conjugate them to targeting ligand. In the case of GalNAc, it's N-acetylgalactosamine targeting hepatocytes through the S-alloglycoprotein receptor. The difference with us and them is probably more in approach from the perspective that our bioinformatic approach is very stringent. So, they've had some challenges in the clinic with microRNA homology, for instance, that they have attributed as the cause for some of the toxicities that they've encountered. We actually screen that out at the bioinformatics stage, so we won't take those molecules forward. We're also very stringent on the possibility of cross-reaction with other closely related sequences and other genes. We screen those out as well. So we tend to be very stringent, and we have the sense that, and we know by their own report that they've had a different approach with stringency. And I think that's made a big difference in the fact that, so far, knock on wood if there's some around here, with the 5 products that we have brought into the clinic, we have not tended to encounter some of the issues that they have. But with respect to the chemistry, there's probably similarities. N-acetylgalactosamine is the same targeting ligand that the whole industry uses for hepatocytes. We have different conjugation chemistry, probably modestly different chemistries in our RNAs, but overall it would look quite similar.
Mm-hmm. So if maybe one step back, do you also do some modification on the RNA?
Yeah. Everybody modifies their RNAs. There are 2 reasons for this. The body has a lot of defense systems, both in the circulation and in cells, that without modification will tend to lead to very rapid degradation. This, for instance, is a challenge with the mRNAs. They can't really be modified, so they're not going to have very good durability. But the second reason for modification was early on in the RNAi story, when people didn't know to modify, they were stimulating a lot of toll receptors and getting cytokine responses and toxicity. The field had to learn how to avoid those with avoiding certain sequences, but also with modifications. So pretty much the field in general uses the same modifications for the most part, and these are in the public domain, and they're not patentable. I think both Alnylam and us and Ionis, we have some things that are proprietary, but we tend not to have to use them very often.
Okay. So I think that's very helpful for sequence specificity or selectivity. I think Alnylam does have one program encountered that issue, and then they actually now developed the second.
At least 2.
Okay, so they sure. Yeah. But the more the concern was the RNA modification that causing, say, potentially some drug class safety issue. So for example, liver or renal tox, which is open questions, right? So we still don't know if it's a drug caused by drug or is the specific disease. So it is open question. So
Yeah.
maybe ask your opinion, have you, if you are commenting, the chemical modification is pretty similar to Alnylam, have you seen any, safety or even from, both from the preclinical, like say monkeys data and the humans data, did you see anything that is similar, like say liver or renal tox?
Yeah, it's an interesting thing. So Alnylam just published a paper very recently, sort of summarizing their toxicology experience. That essentially, said that they see very little in the way of toxicity in non-human primates, going to quite high doses, even for chronic, 9-month, non-human primate studies, for instance. Rats can be a little bit different, and rats occasionally will show some low-level increase in transaminases, some very mild changes in the liver that tend not to increase with dose. But they do see it on occasion, and it seems to be rat-specific. We've seen that occasionally as well. So sometimes, sometimes sequences do it, sometimes they don't. But they tend to be, quite mild changes. And as I said, they don't increase with dose, and they don't increase with time. So our findings are quite similar to what Alnylam recently published. And of course, we consider the non-human primates to be much closer to humans and to be the more indicative. So I don't think it's inherent really to the general sort of chemistries that we use in modifying these RNAs. I think it's more likely sequence specific. And they ran into trouble with AAT. They also ran into trouble with HBV, and in both cases, the approach they're taking is to try to interfere with this microRNA homology, with this ESC plus chemistry. As I said, we just screen it out altogether. We just simply throw those sequences away. But and what's going on with this this in the kidneys with their latest report? It's a strange thing. We haven't seen it in any preclinical toxicity that I know of with them, and we certainly haven't seen it ourselves, and even at very, very high doses. It only occurred in patients that already had renal insufficiency and clearly was not progressive because they didn't have to stop the patients. So it's quite curious. They haven't really given enough information for us to know what they think is even going on. It doesn't seem to prevent those patients from getting the drug they need. So far, maybe it's specific to that disease, maybe to that sequence, maybe even it's something that's happening because of the metabolic changes that the drug is causing and treating the disease. Maybe that's changing some hemodynamics or something. We just don't know.
So like in your clinical experience so far, the safety pretty.
Yeah, we've been very pleased, so far, and we haven't seen anything that's caused patients to have to discontinue the drug or SAEs, serious adverse events or anything like that. So we're feeling pretty comfortable at the moment that what we see in the animal tox is translated into humans and looking pretty clean.
So maybe your first program, the HBV, the most exciting program. So in terms of the depth of response and durability, how do you compare 3989 with ARC 520 and 521?
Yeah, so ARC 520 and ARC 521 were our early generation that were intravenous and included an excipient that caused endosomal escape. And the difference there was that was very rapid. So the subcutaneous drugs like TRIM or like Alnylam's Galnac, they tend to get out of the endosome by sort of outwaiting, by just surviving, unchanged in that environment. And as the endosomes sort of mature and they crosstalk and they fuse, there's a little bit of leakage, and we get enough into the cytoplasm that they work. So they take longer. Whereas our old drug, ARC 520, ARC 521, they were out of the endosomes and into the cytoplasm within maybe an hour or two of administration. So they tended to be faster, but they also tended to wear off quickly. And what we get with the TRiM platform, it's slower, but then it lasts longer, which is why, for instance, you saw with AAT that we had 3 months there. We never would have been able to achieve that with our old technology, with ARC-520 and ARC-521. It's the same thing with ARO-HBV. So ARO-HBV is slower, but it gets deep knockdown and then it persists longer. And then the other big difference, of course, was that what we learned with ARC-520 was about this whole integrated DNA story, and ARC-520 was not designed with that in mind. So it really only worked in a subset of the patients. And ARO-HBV, one of the things we set out to prove here at our very first study was that it would work in all the patient types, E negative, E positive, experienced with nucleosides, naive. So far, it doesn't seem to matter what the patient population is. They're all responding. And that was big news. That's what we designed it to do, but design and execution could be different, and we were quite happy that it did what it's supposed to do.
So maybe one question regarding half-life of, ARO-HBV, in terms of, say, plasma and versus the one get into the cells.
Oh, yeah. So plasma half-life for these drugs is like 5 hours. So we give one of these agents, it's out of the blood, by the next day, it's either vanishingly small or it's out of the blood. So, when we talk to regulators, for instance, about these drugs, we talk about them essentially as repeated single doses. Because we give a dose here, then we give a dose a month later or maybe 3 months later, and it's only in the blood for 24 hours. So, most drugs cause problems when they're in the blood. They're interacting with other things, they're getting in cells they're not supposed to get into, et cetera. We're in the blood 24 hours and that's it until the next time we dose, which is a month or more later. That's one of the neat things about siRNA. I think that makes them generally so safe. But then biological half-life, how long they have their effect, as you can see, we can still have effect 3 months later, and maybe more. So it's a different thing. HBV is a little bit different story, of course, because it's a virus. So, the virus is trying to fight back all the time. When you're knocking down a human gene, the human gene's not trying to fight back. With a virus, it's trying to infect new cells. It's trying to figure out some way to get around you. It's fighting back. So you may still, have a good biological, residence time, but some patients, the virus may succeed in coming back a little bit, while in other patients, the virus really can't figure out a way around you. So it's a little more complicated story.
I see. So when you say biologic half-life, was that referring to once the drug get into the cells?
The knockdown,
the knockdown. So but the RNA also should be stable there, right?
Right. So that's the thing about these direct conjugate drugs. Because of the way we modify them to survive in the circulation, to survive in the endosome, what we now know is that creates great stability in the cytoplasm and in risk also. So, if you have a drug that has enough stability to be effective, it tends to also have long duration. They tend to go together. Potency, duration tend to go together.
Okay. And then going back to the ARO-HBV, so it seems there's no strong dose response between, like, say, 100 milligram and a 400 milligram. Any thoughts why that might be?
Well, I think we're up at the top of the dose response curve. Now, when we started, we expected to see more dose response. We wound up being more potent than we thought we were going to be. That was true in AAT as well. We were more potent than we thought we were going to be. Now we only had, in the HBV, we were very interested in understanding dose response and also the work in E positives, E negatives. So those groups were only 4 patients initially. We've actually expanded those groups to try to get a better look. But we're probably at the top of the dose response curve, even at 100 milligrams, and it's possible that the dose can be lower as we go forward.
Okay. Maybe one last question also on the HPV. Do you think, based on current data, do you think that this could be potential curative, or you think that that will be in combination with other therapy?
It's a hard question to ask. To answer. Our initial first-in-human toxicology work would only allow us to do 3 doses. Even though most people think with HBV, at least initially here, we're going to be treating for a year with finite therapy or so, maybe even longer. It's a different virus than HCV, for instance. The DNA virus, it's much more challenging in a lot of ways. So most people have thought we're going to have to at least start out treating longer term. We just wanted to make sure that we were active and would we work in all the patient populations. I think what we do know today is we know that 3 doses given a month apart on top of a nuke is not enough to cure a lot of people. That doesn't mean that, for instance, a year of ARO-HBV, on top of a nuke would not maybe cure a significant number of people. The betting in the field, most investigators in the field believe that it's more likely to take, say, 3 drugs, rather than just 2. I was just at a conference, an endpoints conference, HBV, literally this weekend in London. And I think that the field generally believes at this time, with everything that's available today and what we know, that the core regimen is going to be nuke plus RNAi. But the question is, what else may be necessary? And most people think that something else is going to be necessary rather than just the 2, certainly to get to the very high response rates that people are hoping for.
That's very helpful. Thank you very much, Bruce.
You're welcome.
So we will have a breakout session across the hall.
Okay. Thank you, everybody.